Thank you, Elijah.
Thanks, Mighty, and thanks, Michael and Sanjay and Steve and the team for asking me to speak today. I'll be addressing long QT syndrome in the context of athletic endeavor. The first thing I wanted to present to you was this initial statement that came out in the ACC and AHA specific scientific statement around the evaluation and management of patients and athletes with channelopathy and the need for a comprehensive evaluation by a heart rhythm specialist or genetic cardiologist with expertise in the area. And I think that's been repeated now in all the guidelines related to not only athletes, but genetic heart diseases. You do need some expert input into these cases, and they shouldn't necessarily be managed at a more generalist level, particularly because the interpretation of the ECG anomalies in athletes, as you've already seen, the structural and ECG anomalies can be influenced by physiology as well as pathology, with the physiology of the athlete potentially leading to misdiagnosis or overdiagnosis. When we talk about the diagnosis of long QT syndrome, clearly the longer your QT interval, the greater the chance that you have long QT syndrome. And these are the current ESC guidelines from that point of view from 2022. If you have a QTC of over 480 milliseconds and repeated ECGs, with or without symptoms, or you have a diagnostic score, the long QT syndrome score, Schwartz score, as it was originally called, then you are recommended to be diagnosed as with long QT syndrome. You'll also see there that genetic testing is part of it, and if you have a positive genetic test, then you'll get a diagnosis of long QT regardless of your QT prolongation. Also, in the setting of a more moderate QT prolongation, if you have suspicious symptoms, then you may be also allowed to diagnose that, although that's a 2A recommendation rather than a 1, so should be considered. Remember always to remove the possibility of a secondary cause of prolongation, and this is potentially important when it comes to athletes, and this was highlighted by work from Sanjay's group originally back, I think, well over a decade now, looking at the prevalence of QT interval prolongation in the athlete group. And at that stage, the cutoff that was being used was 440 for males and 460 for females, according to the ECG criteria at the time. And that indicated a much higher prevalence of significant QT prolongation in athletes than you would expect for a relatively low yield of diagnosis or prevalence of long QT syndrome, 1 in 2,000, as opposed to 1 in 125, 1 in 250, depending on that evaluation. And in fact, the features of long QT syndrome, such as symptoms, such as family history, such as genetic findings, were only evident in those who had a much more severe QT prolongation of more than 500 milliseconds, which is usually our cutoff for severe in the long QT population. So raise the question here, do athletes in fact have higher long QT intervals and a moderate QT prolongation would not necessarily be evidence of long QT syndrome itself? This was followed by a more recent study looking at a large number of athletic individuals presenting to Leah Crotty and Peter Schwartz's clinic in Milan. And there were around 300, just over 300 individuals presenting here with QT prolongation. They excluded a number who were thought not to be related to long QT syndrome for other reasons. They were incorrect referrals. They undertook genetic and clinical testing and determined that there was a clinically affected group over here forming the majority. And they detrained these individuals for a period of time, showing a drop in QT interval on average of around 20 milliseconds. So in the clear long QT, on clinical grounds and on genetic grounds, your QT interval can still be prolonged by doing athletic activity, and detraining removes it. But if you looked at the other cases where there was QT prolongation, but there wasn't sufficient evidence to make a diagnosis of long QT syndrome at the output, detraining revealed a much larger drop in the QTC duration, QTC interval. Here, an average of -70 drop, so 70 milliseconds drop in the QT interval. And this clearly suggests that we need to be careful, particularly in that moderate QT prolongation group, of diagnosing long QT syndrome without other diagnostic cues and evidence. So what are those other diagnostic cues? There may be some subtle changes on the ECG that are more marked in the long QT patients. So often we'll see a bit of the dome and dart appearance in our young athletes in V1 to V3. But if it's more marked than that, if it's more than 3 leads where you're seeing evidence of T-wave notching, then start to think that this asymmetric T-wave morphology is not normal. We do still see some normal patients with these sorts of patterns, but it's more likely to indicate long QT. Get them on the treadmill, see what they do with their QTC. How does their QTC prolong or change with exercise relative to the heart rate? And the most useful period coming from work from Andrew Cran's group by Ray Tsai, but when he was based up in Canada before he went back to Australia, you'll see in the recovery phases that the QT interval is longer in long QT carriers versus non-carriers, and this is in the family setting as well as all comers to the clinic. So it's a potentially very useful test even in index cases. And this is at 1 minute and 4 minute recovery of carriers versus non-carriers. So this is probably the best phase where you're able to see these normally. And so this is an example from one of our LQT2 patients who has a normal QT interval at rest on their baseline ECG, and you'll see their T-waves even look pretty normal as well. And then on the recovery phase, you'll see they've developed this T-wave biphasic pattern, possibly a TU wave, sometimes difficult to interpret and sometimes also difficult to measure. And remember, that can also merge with the P wave, and that may make your measurement virtually impossible, but it can still give you potential diagnostic clues. But don't over-rely on the single index alone, because you may still end up over-diagnosing cases. But this does feed in 1 point in the Schwartz score. So remember, where does the T wave end and the U wave begin can sometimes be a challenge, and expert guidance may still be necessary to help from that point of view. Another proposed approach is using lying and standing ECGs, and this is pioneered by Sami Viskin, replicated by others. It's a very simple provocative maneuver, and we do it at the beginning of the exercise test just so we've got a full set of data. 2 minutes lying, 2 minutes standing gives you enough time for QT hysteresis to occur in both states, and then exercising. And it makes you realize when you see these ECGs that if you get people from lying to standing and exercising without any delays, you could get very odd changes on your exercise testing if you're not more systematic in approaching exercise testing that way. So it is a continuous ECG monitor, and the initial test, and probably the most useful test, is the maximal QT stretch, but you can also see at 2 minutes whether that sustained stretch is still present, called the QT stun. And it's potentially quite useful, again, at marking out the more likely patient, but it hasn't made it into the Schwartz score as yet. So this is just more of a soft diagnostic cue. And this is an example of an LQT2 patient who's exercising. Clearly the standing is the artifact, the increase in heart rate, and you'll see that the QT has increased to 556 milliseconds, which in this case, and this is the QT stretch, we have the shortest PP interval as well. And this is an example of a female LQ21 going from resting. So we've got a borderline QTC there of 452 milliseconds, or borderline QT of 452 milliseconds. And with standing, that prolongs at 19 seconds to show that evidence of stretch QTC of 520. So it can bring out latent QT, long QT syndrome in the genotypically abnormal patient. Now, clearly, this is much more marked. This is not just a diagnostic cue, this is a click in the eyes. It's T-wave alternans. So if you're going to see with exercise or on halters that there's a lot of variation in T-wave morphology, and this is obviously a very extreme version, then that's potentially going to raise your concerns. So look for more subtle variation, but always realize that don't sort of look at that from a beat to beat point of view, not from a respiratory variation point of view. Or you may even see evidence of late-coupled ectopy and triggering of arrhythmia. So here's an example of late-coupled ventricular ectopy, gradual worsening of repolarization, couplets, and then followed by torsade de pointe, and then resolution afterwards with a more normal QT interval afterwards at the end of the arrhythmia at resolution. Now, genetic testing is clearly very useful in diagnosing a long QT syndrome. In the standard cases, in patients who've got definite QT, you could see rates of 65, 70, 75% of likely pathogenic variants in the top 3 genes over here. The more stringent your diagnosis, the better the yield. If you're looking at borderline athletes, you're more likely to see lower yields and intermediate long QT syndrome around 30%. So beware of using gene testing alone, but it can actually be useful in your suspicious cases. So again, that needs to be done carefully with expert hands, because you can sometimes throw up findings that you don't know how to deal with, like variants of uncertain significance. But if it's negative, it may reduce your threshold, or may raise your threshold for considering the diagnosis of long QT syndrome. In terms of therapies, well, how do we then treat the athlete in the situation of, or the sports participant at least, when there are concerns about risks of adverse events with long QT, and particularly those in exercise that are associated with LQT1, much less so for LQT2 and LQT3. So maybe you have to be less anxious about exercise for, according to genotype. And also be aware, and this is data from Silvio Pirori's group, that there is this pyramid of risk. The really high risk are those that are presenting with the most overt long QT syndrome, even if they're asymptomatic, are right at the top of the pyramid. By far, the majority actually have relatively low risk, and we should be careful about penalizing them too early, given that their overall lifetime risk may be reasonable, but their individual risk with exercise when they're most active may not be so. And in fact, if they're taking beta blocker therapy, then you get quite significant improvements in outlook. So therapy is potentially, for most of these who are asymptomatic, moderate QT prolongation at most, will be lifestyle. So that's avoiding drugs that prolong QT syndrome, treating hypokalemia or preventing hypokalemia, so ensuring that there's isotonic rehydration during exercise, and certainly after illnesses, gastrointestinal illnesses. And then drug therapies, of course, beta blockers. There may be a role for mexiletine as an add-on therapy in LQT2, but it's a very good therapy in LQT3, where beta blockers may be less useful. And then there's sympathectomy and ICD for much more severe cases, but these are not the ones where you're really wanting to focus on making diagnostic and management decisions. In terms of exercise recommendations, the historical recommendations were very restrictive. The Americans less so than the Europeans. No competitive sport at all, and 1A sports, more liberal than LQT3, as you'll see. The no restriction at the bottom there for the Americans for genotype positive, phenotype negative, apart from LQT1. And the 1A sports for the rest of them in the Americans just obviously was potentially very limiting in terms of the range of sports. And most of you will be familiar with these Mitchell criteria. And we've already talked about the psychological implications that could be severe for these individuals. Mike Ackerman at the Mayo Clinic has pioneered the return to play for long QT syndrome patients, and his first study took individuals who are genotype positive, phenotype negative, as well as genotype positive, phenotype positive, and only one of all of these individuals had an event over 650 athlete years of follow-up, and that individual had an ICD already that is high risk. This resulted in the support in the ACCHA guidelines of return to play for these individuals who are well treated. Although ESC 2020 guidelines have still been much more conservative than the American guidelines. Anybody that has genotype positive, phenotype negative could be considered for exercise, for normal exercise, depending on various other factors. But if they've got any evidence of moderate QT prolongation or more symptomatic, then it's a class 3. So still there's a real tension between American and European guidelines. And since then, there's been a follow-up study from Mike Ackerman's group again, looking at an even larger group undergoing a rather detailed protocol involving a lot of shared decision-making between the individual and the club and the college, university, and promoting return to play in a very structured way on treatment. I won't go into the full detail of this, but it's around 500 athletes were evaluated with a very wide range of sports. They're not all doing 1As, that's for certain. And from that group, with that excellent range of treatment and program, there were no deaths due to long QT syndrome. Most athletes in the group, so 465 out of 494, were a breakthrough cardiac event free. And those who actually had rates, well, the actual rate was 1 event per athlete year, but those who actually had events, most of those weren't due to sports or in the setting of sports. They were at home. They were doing other activities. So it wasn't sports related specifically, where you potentially have all the life-saving measures available anyway on site. So in conclusion, mild to moderate QT prolongation may be physiological. We need to consider whether detraining, sorry, Sanjay, detraining may be useful in these individuals when you're really worried. But genetic testing can also play a role, but this needs to be done in expert hands. Avoid QT prolonging drugs, avoid the dehydration around sport and also gastrointestinal illness. Have an emergency action plan available as shown and as already previously mentioned in other talks. Beta blocker plus or minus other treatments, and sports participation may be more liberal depending on genotype and therapy and depending on how European guidelines evolve over time. Thank you for your attention.